Welcome to the Healing Pain Podcast with Dr. Joe Tatta. Each week, we interview top experts in physical therapy, pain science, and integrative pain care. You'll learn the most up-to-date information for treating and reversing persistent pain. This podcast is for educational purposes only and not intended to be used as personalized medical advice. And now, here's your host, Dr. Joe Tatta.
Hey there, thanks for joining me for another episode of the Healing Pain Podcast. Today we're talking about integrated health programs for mental well-being. Joining us today is Dr. David Tomasi. He's a psychotherapist, researcher, and philosopher, as well as the author of the best-selling book called Medical Philosophy, and the co-author of a paper which we'll talk about today called Positive Patient Response to a Structured Exercise Program Delivered in Inpatient Psychiatry. That was published in 2019 in the Journal of Global Advances in Health and Medicine. It was also the most read research item from the University of Vermont. He is a member of several national and international Academy of Sciences. Dr. Tomasi works in the inpatient psychiatry unit at UVM Medical Center and teaches at the University of Vermont and the Community College of Vermont. On today's episode, we'll discuss how the combination of psychotherapy, nutrition, and exercise together can help patients in an inpatient psychiatric facility. This is, of course, an important topic because approximately 50% of those with chronic pain also struggle with anxiety and or depression. About 10% also struggle with PTSD. And this episode, as well as this podcast in general, really kind of dives into how we can integrate strategies, integrate different types of therapies and approaches to help people living with chronic pain. Okay, let's begin and let's meet Dr. David Tomasi. Hey, David, welcome to the Healing Pain Podcast. It's great to have you here this week.
Hey, Joe, thanks for having me.
I was trying to think today before we set this podcast up. I'm like, how did I come onto your work? I know I found one of your papers, but as I started reading through like your bio and your different degrees and some of the great research you're doing, I think what you're doing is actually really pivotal, not only in the field of psychotherapy, but also it starts to have these overlaps into different areas of exercise and nutrition and mindfulness, and so many of the different things that we talk about on this podcast that have to do not only with chronic pain, but many of the chronic conditions that we see today. Give us a little bit about your background. Obviously, you're a psychotherapist, but how did you kind of get involved in more of like this? You have like an integrated flavor to a lot of the things that you're doing. How did that come about?
Thanks for the question. My background was a combination of neuroscience and psychology at first. Although my first degree really was in visual and performing arts, and I entered the field of psychology through art therapy. That was my first interest. But then I wanted to expand on what you could call the nature basis of our profession, the nature-nurture debate. So I really wanted to know how the brain worked, in particular, the neurotransmitters and the emotional cognitive response to things. And then I always been exercising. It was also a very big passion of mine. I practiced martial arts for several years, and I was trying to combine these two passions of my life. So the neuroscience background and the exercise science. And then, of course, the ultimate goal was to help people in general. So as a psychotherapist in an inpatient psychiatry unit, I have the opportunity to witness the benefits of the more holistic approach to medicine, this mind-body connection, you could say. So that's in short my background. And of course, I also teach at the University of Vermont in the Integrative Health program.
Right. So you're teaching as well as doing clinical research at University of Vermont.
That's correct. Yes. Yeah. My clinical head is the University of Vermont Medical Center, the inpatient psychiatry unit. And then I teach for this Integrative Health program, which is a shared program by the Larner College of Medicine, hosted in the College of Nursing and Health Sciences. And
just, it's an interesting program. Tell us about the aim of that program before we talk about your paper.
The University of Vermont has always been one of the, at least in my experience, one of the very interesting places nationwide for what used to be called complementary and alternative medicine. However, due to the strong emphasis on evidence-based science we have here at UVM, our program is really attempting to bridge the gap between some, I wouldn't say lack of scientific knowledge in certain areas of complementary medicine, but we will try to provide more on evidence-based clinical background as well as evidence-based clinical randomized controlled trials. And the fact that UVM has been such a fertile ground for this type of research, a very strong emphasis on science makes this program quite interesting. And we have different areas of specialization, including health coaching, integrative healthcare. So we have students from all different backgrounds, especially from medicine and nursing, but also from architecture, from computer science and human development, family studies. So it's really a hybrid fertile ground for self-discovery and scientific enterprise.
Yeah, I appreciate that because this oftentimes complementary alternative medicine is thrown around a lot like it's evidence-based. And of course, there is some evidence, but there are certain techniques and therapies that have just been studied more deeply with RCTs and systematic reviews, and some that we're still learning about. And I think it's interesting to learn about those. So I came across a paper of yours, and the paper is called Positive Patient Response to a Structured Exercise Program Delivered in Inpatient Psychiatry. It was in the May 2019 Journal of Global Advances in Health and Medicine. And what I loved about your paper is that you're using one of the primary modalities in the paper is exercise. Tell us what the aim of that paper was and give us some context about the participants in that study.
The whole project started due to the very hard work that my colleagues and I, especially Sherry Gates and Emily Ryans, have been performing on the inpatient psychiatry unit. They're both psychotherapists, just like myself. And the idea for exercise stemmed from a constant conversation we have had over the years in inpatient psychiatry to provide more of a holistic approach to the already delivered typologies of intervention, which are psychotherapy and pharmacological interventions. And we won a grant in 2017 that allowed us to remodel the previously existent exercise room on Shepardson 6, the more acute unit, and build from scratch a brand new gym on Shepardson 3, which is a unit in which we deal mostly with depression, mood disorders, bipolar, borderline personality disorder, etc. And we were aiming at offering a more omnicomprehensive background to our patients. The idea was to complement pharmacology intervention and classical behavioristic approach, so cognitive behavioral therapy, dialectic behavioral therapy, to forms of therapy that are usually considered integrative health. And we already practice art therapy, dance movement therapists, yoga, mindfulness, meditation, Tai Chi. But we really wanted to focus on physical exercise, also strenuous exercise, because the research out there is pretty strong in terms of the modulating effects, serotonin, dopamine, beta endorphins, GABA receptor due to strenuous exercise. And thanks to first the grant and this brand new research we presented this year, we were able to do just that.
So these are obviously this is an inpatient psychiatric part of, is it a psychiatric hospital or is it just a part of a hospital that has an inpatient psychiatric floor to it?
It's part of the University of Vermont Medical Center, which is a hospital with all different specialties. So we have two units within the Department of Psychiatry within the University of Vermont Medical Center, which is the hospital affiliated with our university, the University of Vermont.
Right. So you took a place in the hospital that was maybe, let's say, underutilized, and you created a gym atmosphere, if you will, to support your study.
That is absolutely correct. Unfortunately, nationwide, the inpatient psychiatry facilities, whether inpatient psychiatry hospital or clinics that also offer any type of physical exercise, really, really limited. And it's really unfortunate because aside from the, I would say, incredible results from our research, there's plenty of meta-analysis and RCT out there that, in the previous years have linked at least, positive benefits from any type of physical activity. So it's really unfortunately surprising that only few facilities would offer that. So we are at the forefront of this type of research here at UVM.
Yeah. I mean, you mentioned CBT before, and CBT has wonderful research for treating depression. But if you really look at a lot of the studies, and this may be, debated by some people, but exercise is potentially a better intervention at times for certain people for depression. So it's interesting that you as a psychotherapist are turning toward that. And I think as a physical therapist, I think it's interesting because these are some of the things that we've been preaching for a long time. Tell us about the exercise intervention specifically in your study. What did it consist of? Sure.
We've been also very lucky to work in collaboration with the Integrative Health Department, and our Director of Education, Dr. Karen Westerveld, she's a physical therapist herself, a doctor in physical therapy. So she's very, very sensitive in a positive way to any type of research that will involve exercise in this regard. We followed closely the recommendation of the American College of Sports Medicine in order to provide a type of exercise sessions that will work both on anabolic, catabolic factors, as well as heartbeat, stretching, warm-up session, modulated exercise, because of course, due to the restriction of an inpatient psychiatry unit, we cannot do weightlifting, for instance. So we have several bikes, both standing or recumbent bikes. We have both rowers and water rowers. They also provide a synesthetic atmosphere with, mimicking the sound and the movement of the water itself. We have yoga mats. We have gymnastic balls. We have ellipticals. We really have quite a bit of equipment. And we were also utilizing the help of the Department of Exercise and Movement Science at the University of Vermont to target individualized plans for patients that might otherwise be limited in their range of motions, for instance. And this is for two main reasons. The first one is to provide intervention that will work right in the moment. So for people that might only be able to exercise, let's say 30 minutes, 3 times a week in between psychotherapy session, that's something we can implement right away on the unit. And in fact, that's what's been happening. And the second reason, which is even more important, is to provide, from a holistic standpoint, the tools that a patient might need upon discharge. Because unfortunately, especially in mental health, one of the risks is you do a wonderful job while you're in a unit, in a supervised environment, but then life happens, and upon discharge, there are only a few people that can actually follow up. Also due to restrictions in economic terms and financial, issues that a patient might encounter. So a lot of our exercises were free body exercise, so the patient does not have to actually necessarily pay for a gym membership if their insurance won't cover for it. So that's the type of work we've been doing here.
That's great, though, because then they can take it home, and hopefully that exercise program will carry over and they continue to do it, at home or wherever they wind up going to next. I'm just curious, how long does the average patient stay in this inpatient facility for?
That's one of the hardest questions, just because of the nature of our job. I would say that downstairs, so to speak, on Shepherdson 3, which is more, a mood disorder, behavioral disorder, depression, I would say the average length of stay is about 2 to 3 weeks, I would say, versus upstairs due to more neurologically based presentations. And we should take neurologically based with, a grain of salt, because, the research on the genetic background, keeps varying. But anyway, patients struggling, for instance, with schizophrenia, then the length of stay, it's longer in many, many cases. And it also has to do with some clinical and legal aspect related to medications, admission rates, as well as status.
Yeah. And how long was your study?
So we've been doing the study for 12 months, and we started, of course, the study right after we completed the gym. So the grant that led to the exercise study was awarded in 2017. And then, by the time we built the gym, we created the structure and quantity and quality analysis. Then over the following 12 months, we collected data.
Yeah. So the American College of Sports Medicine guidelines for exercise for normal, healthy individuals is, let me just say, it's quite full in terms of the amount of minutes and intensity people have to participate in on a weekly basis. Were all of your patients in the study able to meet those guidelines, or are you modifying the exercise based on their feedback?
I would say both. So downstairs, again, on Shepherdson 3, the fact that the biggest diagnosis in terms of the statistical prevalence will be depression. So patients were more apt to just be involved in exercise and were closely following those guidelines. Of course, on Shepherdson 3, Shepherdson 6, just because of the nature of the cognitive struggle that some patients might have, they were not as able to perform as well in a sense of following the guidelines. But what was interesting is that we were very successful because for other forms of therapy, including DBT and CBT, patients in the past have declined group attendance, and group attendance here at UVM, it's not mandatory. We have very patient-centered facilities, so patients' rights always come first, and that means that we don't really have any extra leverage to convince patients to attend groups. But exercise actually really opened the gates for a more holistic approach. So while they were doing exercise, even if they were doing exercise for, let's say, only 10 minutes, then they still spend the rest of the session dialing with us and discovering other types of tools that they might have used to nurture self-esteem, and by default then coming to the next session and attend the session for 30 minutes while exercising. So it was a win-win situation. And then, of course, the fact that we were customizing the exercises meant that we used the guidelines from the American College of Sports Medicine as a safety guideline, so to speak, the parameters that we want to utilize to make sure that everybody is safe from both a physiological and psychological perspective. And within those parameters, we're pretty free to move around the needs of every patient.
Mm. In addition to exercise, you also utilize nutrition education. Talk to me about how that was part of the study and how that informed their care and their outcomes.
Yeah, we were lucky because each of our psychotherapists, beside the clinical psychology background that we all share, have a different and very targeted background. So for instance, in the case of our research, Sherry Gates, my colleague, her background is in counseling, and Emily Rines has also background in dance movement therapist and nutrition. So we were actually working on the two main pillars of exercise. So one of the concerns a lot of patients had, one was more on a pragmatical perspective. Why would I exercise? I like food so much, and I don't know what the point is to lose weight and gain weight again. I feel it's kind of a waste of time. And we're targeting nutrition education, similar to what will happen in a health coaching session. We were really empowering patients to make more informed choices and beyond what the classical approach on, calorie count or balancing proteins and carbs would be, but really working on empowering patients to be more in control of their health. And that was one aspect. And the other aspect was that a lot of patients, especially those struggling with depression, were missing the main purpose of why would I need to get better? My life feels empty. My life feels a struggle. So nutrition is really at the bottom of my interest. I just don't care about my own body. Emily Rines was really instrumental in this sense because we use not just a different cognitive or philosophical background, but really different neural mechanism in the brain to target that element. Because of course, attached to nutrition and food intake, you also have the emotional response. You have a pleasure center mechanism. You have a hippocampal structure that are playing a role. So it was a psychoeducation session prior to the beginning of every exercise. So the patient will start a day with a nutrition education session. Then they will exercise. After the exercise, they will have the time to relax, take a shower, and then they will have lunch. So they will have this holistic, well-informed presentation on the way they can think and the way they feel about their body. And plus, the other thing to be said is that the research is pretty straightforward in regard to the importance of the gastrointestinal tract on neurotransmission itself. Mm-hmm. So, gut health is mental health after all.
Yeah, that's great to hear you say that, because there are a lot of mental health practitioners that haven't yet ventured into that realm of gut health and nutrition. They've heard about it. Yeah. It's talked about in the media a lot, and we talk about it on this podcast all the time, but it's great to hear a psychotherapist start to look at that as far as how can we help someone from a holistic perspective. As I listened to you talk, so you talked about exercise, you talked about nutrition, you talked a little bit about kind of some of the more catchwords in psychotherapy, CBT and DBT, but it actually sounds like the program you created with regard to psychotherapy, yes, you're a psychotherapist, so there is always that element there, but it sounds like it's more of like a motivationally interview perspective to help patients make change and to accept where they are.
Thank you. That's a great question. Yes, that's what we're at least aiming at. So the way our inpatient psychiatry unit is structured is we have an inpatient psychiatry unit multidisciplinary treatment team that really makes those changes happening on a daily basis. So the four main professional figures, psychotherapists or psychologists, psychiatrists, nurses, and social worker meet every day for the morning clinical rounds. So we need a plan for the day. So we have this ability to deliver customized care that is based on this mutual understanding of the clinical strength each of us brings to the table during clinical rounds. And we are also supported by mental health tech, licensed nurse assistants, and secretaries. Everybody's really playing a major role in the delivery of care. In terms of the schedule, the clinical schedule, we are lucky because we're very flexible. So to give you an example, on an average day, you might have a morning clinical rounds that is half shared with the patient. So we have this open dialogue model, this patient-centered round. So the patient is actually taking part in whatever clinical decision making is shared during the clinical morning rounds. And that's really part of motivational interviewing and empowering health coaching. And then we have the central part of the day. So we have 3 sessions, one around 10 a.m., 11:15, and 1:45 that are psychotherapy based. So you may find CBT, DBT, you may have self-esteem, grief and anger, boundaries, self-image, addiction and recovery, substance abuse, these type of groups that are very cognitively based. And then each day starts with a morning check-in and evening check-in in which we actually set a pace for the day. And then every other element, every other spot during the day is pretty much exercise or Tai Chi or yoga. So we spend a lot of time working with our bodies. And that's something that provides a good rhythm, because part of being a patient in patient psychiatry, and we only work with adults, is having a stable routine that also helps frame the day. So having, I would say, almost a sense of duty every day, something that's waiting for you, something that has to be done and that motivates patient. I need to do this, I need to do this. And the support the team creates a sense of familiar environment as well.
Yeah. It's a great structure. It sounds similar to many of the interdisciplinary or multidisciplinary pain clinics that the U.S. used to have more of them. We still have some, but not as many as we need. So let's go back to your study, and now we've gone through some of the details about it. Tell us what some of the outcomes were, and how you first. What did you use to measure the outcomes, and what were the results?
The results were very exciting. To be fair, we were expecting positive results in general, just because, again, there's a big body of evidence out there on, generally speaking, the positive benefits from exercise, any type of exercise for depression. What was really surprising is that we were between 93 and 95% positive results across the spectrum. So both units, mood disorder, neurologically based disorders, personality disorders, schizophrenia, schizoaffective disorders. So the vast majority of patients, the 90th percentile, benefited from exercise. Again, saying that there was some difference between the type of exercise they were doing, but in general, it was a very, very high percentage. We were also lucky because it was a very controlled environment, so we were able to follow patients closely. So there were similar sites performing the PAS on an outpatient setting, but of course, it's hard to monitor the benefit if something else happened in their lives on a daily basis, because you don't have the chance to observe patient. In our case, it was very controlled, as controlled trials as you can get. And also, we wanted to emphasize the qualitative analysis. So beyond the numbers that were very exciting for us, we really wanted to create a survey, a questionnaire that focused on pain perception and mood perception. Granted, one of the big question we had is, how reliable are surveys that are qualitative structure in comparison to, for instance, collecting vitals, which we did anyway, and we are planning to expand this research. I will mention that in a few seconds. So how reliable is this qualitative analysis? And the big answer is, if you have very strong data and you have pretty good vitals, but then those numbers do not reflect in the way a person feels, then you kind of miss the point. It's great for the research, it's great for us researchers, but we wanted to make sure that the patient actually felt the difference. And these surveys did not only target the general well-being pre-post exercise, but also their mood, their sense of self, their favorite exercise, and whether they will envision in the near future continue exercise or making some life changes. And that was really, really exciting. So the narrative part, as much as the numbers were great, was even better, because patients were really able to actually work in a pragmatical way. We do that in CBT. We target cognitive distortions. We do motivational interviewing. But the fact that the patients were able to actually utilize their own proprioceptive apparatus and nociceptive apparatus, so the perception of pain and lack thereof, was fantastic.
Yeah, I appreciate that, because obviously so often we look at studies and there's quote unquote statistical significance and people get excited about that. But the qualitative part brings the patient story in. It's like, okay, well, here's the stat of how someone got better. And here's how they responded. Here's what they said about the quality of their life and how their life changed based on the study. So there's a few studies that actually, weave those two together. So I like that you included that in your study. From the perspective of professionals who might be reading your study, I guess we could take psychotherapists first, which includes psychologists and social workers and all sorts of different kinds of counselors and marriage and behavioral therapists. How does it influence their work and potentially their clinical work going forward?
I would hope that beside what is becoming somewhat of a commonplace, to throw out the term mind-body medicine everywhere, that people really pay attention to what that means, because those two are not two separate fields. And there's something to be said from a more theoretical, philosophical standpoint. Now, one of the reasons that I personally decided to join my team and started working on this research was a sense of duty, a sense of expectation, so to speak, that I had when I was discussing existential questions with my patients. And that was really related to the nature-nurture debate, or to the mind-body debate, or mind-brain debate. And of course, there's no time here to do a philosophical discussion, but those topics are very complex. But in practice, one of the things to keep in mind is that regardless of the philosophical, religious, or ethnocultural background patient might have, it is a fair assumption that at least we could take that there is such thing as a mind. You can call it a psyche, you could call it a soul, depending on your background, and something matter-based like a body and a brain, right? And this assumption is healthy in a sense that it really provides the framework upon which any type of psychotherapeutic intervention is based. The fact that by way of training your thoughts, you can have an impact on the way your brain works. And that's one of the greatest things about psychotherapy. But then by brain, we should really think about embodied cognition, that we think through our body. So the brain is a fundamental element, and of course, a little biased because I love my neuroscience research. But the truth is that we think with our body. And philosophy aside, the research is pretty strong. So I would hope that my colleagues, whether they're focused more on pharmacological intervention or talk therapy, they will understand that those things should not be kept separated. That when you interact with a patient, you interact with a mind and a body. And what the mind does not want to accept right away, and that will be the case, for instance, of typology of behavior that might be obsessive or compulsive or traumatized in general, then you might reach that inner core of their mind or soul through their body. So that's the type of change that I hope my colleagues will implement more and more.
So does that mean you hope that there's less sitting in traditional psychology and maybe some more moving, which can be tough for psychologists? Well, it's not just tough for psychologists to change their practices. It's tough for any practitioner to change their practice patterns and habits.
That is absolutely correct. There is something that should be said about the long-term research structure that we have implemented. So this exercise study was focused on the status quo, so to ameliorate, to improve the situation in patient psychiatry unit, and by way of testing it out in our hospital, possibly, share our results nationwide so other facilities could do the same. But then in the long run, our next research actually will involve more holistic approach to virtual reality and olfactory bulb stimulation. And in short, what we're trying to do, our research will probably start in about a month or so, a month and a half. We will work on those cognitive structure and neurological systems that will otherwise be unutilized for patients that, for instance, have had major physical injuries and are therefore not in a position of practice any type of exercise. And we will use the same neurological structure as if they were moving for real. And similar to what happened in a neurological response when you think about, tasting a lemon, you start to salivate, just automatic response on a neurological level. That's what we're going to test starting, again, in a month and a half. We had the wonderful opportunity to work with this company called OVR Technologies here in Burlington, Vermont. And OVR stands for olfactory virtual reality. And it's a combination between the olfactory bulb stimulation, and our sense of smell is one of the most powerful senses because it really almost completely bypasses the thalamus and goes straight to the cortical area. So it has a really strong motivational component to it, combined with virtual reality. So in practice, we will have this virtual exercise session that will stimulate very similar cortical areas as if you were exercising for real. You can deambulate around the natural environment. You can interact with the plants and trees and flowers and roast marshmallows, so that the brain will start to get used to this 360 type of movement. So you set the standard for neurological safe response. And with that said, then once your brain is able to see, to feel that there is something more out there, then the whole body will respond. It's like explain to someone who does not know how to read the alphabet how beautiful it is to read a book. If you don't have the experience, it's hard for you to guess it. So for our patient that might be otherwise not able to exercise right away because of limited range of motion due to physical injury or because depression keeps them in bed all day, then the second part of research will provide us with more cognitive leverage to achieve just that.
So in essence, you're setting up a safe context for them to start to develop an engagement of potentially moving later on, whether it's weeks or months or potentially even years down the line for them.
That is absolutely correct. And again, we have pretty solid evidence that, at least from the neurological standpoint, those cortical circuits are the ones that are responsive for our emotional response, and they also involve, the mirror neuron response. The teaching by example, well, that's what it is. So since we have the neuroscience and we have a pretty good theoretical framework upon which to base our intervention, then I really hope that us as practitioners would also, move more with our patients, and maybe they will change the structure of our clinics too. In our offices, will become more, I would say, customer friendly. I don't like the term customer for my patients, but you know what I mean.
Yeah.
So
that's the thing. As I was reading your study, I'm like, what? So I worked in a hospital for the first 3 years of my career, and the hospital had an inpatient psychiatric floor, which I would occasionally go to help certain patients. And to be honest with you, it was kind of a dark place. There was not a lot of lighting. There was a bad, probably like, if I remember correctly, blue color on the walls. And there wasn't a lot of light, and the windows were small, and there were bars in the windows. I can kind of go down the list of different things. But when I read your study, in the hospital itself, you started to create more of a nurturing, healing environment and context for patients to recover in. And that's what's interesting to me, because if and I don't know how many papers are out there like yours, but then you start to look at, okay, what is our healthcare system like, and what do we need to deconstruct and rebuild that can help people?
That's a very good observation. Yeah, in our study, beside the exercise itself and of course the fitness equipment we purchased, we made a lot of changes to the environment itself. We had ceiling tiles, we have posters, we have nature images everywhere. We have a healing garden downstairs, and the patient can access this garden twice a day. We have a big veranda overlooking Mount Mansfield, a beautiful view here in Vermont. So it's beautiful in the summer. We have the foliage season, so it's really great, especially during those change of season that might affect, seasonal affective disorder as well as depression. It's really great. And again, there's something to be said about the expectation of this type of therapy, because unfortunately, as much as I would say that here in the US, more and more holistic approaches are utilized, in medicine and psychotherapy and everywhere, there is still some sort of suspicious attitude towards it, some of which is justified because unfortunately, especially in the realm of complementary and alternative medicine, some of the claims are really not evidence-based, and we should really be careful about that. We need it's a fight for science that we should fight every day. But at the same time, the general attitude is that all those approaches are kind of nice, kind of embellishing the therapy, but they're not really making major changes. Even exercise. Yeah, if you're suicidal, you need to take an antidepressant and do psychotherapy. If you have time, you can also do exercise. You really have to change that mindset. Granted, the opposite extreme can also be a risk. For instance, thinking that if you have a mental health disorder, you could just pack your bags and move to an ashram in India and you'll find your soul and all your problems will be solved. That'll be fantastic if it was the case. Maybe a little expensive to travel over the place, but maybe not as expensive our current healthcare system in the US. But it's unfortunately not the case. Mental health disorders are real disorders, as real as any other medical problem. So we should try to combine the two poles without any extreme views on it. But the body is the host of our brain, at least, and for the one who believes in the soul, that too.
Yeah. So in Europe, you're saying there are parts of Europe that may be a little bit further along in terms of providing integrative healthcare to people who need it.
There is something to underline in terms of the differences. Obviously, there are two very different systems. Granted, you could say that EBM, so evidence-based medicine in Europe, is the same as the United States. We share research, we share meta-analysis, we share trainings. However, there are some important differences. One big difference is due to the historical anthropological framework. There was really different. And I want to give you a straightforward example. The way medicine is taught in the West is pretty much a product of the Age of Enlightenment, I would say. So the 1700, 1800 on. So this strong emphasis on the scientific method, the positivistic attitude, the fact that we need to test our claims, that we cannot rely on anything that's either philosophical or spiritual. We need to test our claims. And it's a fantastic thing. That's a thing that allowed to discover vaccination, allowed to discover, antibiotics. So it's a fantastic thing. One of the differences is that in Europe, this type of medicine was a natural evolution from millennia-old tradition. So it was a kind of a gentle progression, so to speak, with, setbacks, and that's how science progresses. In the US, unfortunately, there was some sort of cutoff, some of an interruption between the tradition, Native American holistic tradition, and the imported European evidence base that came from countries like, the UK, like Germany, like Italy. So we need to rediscover those roots that were really uprooted in this part of the world. So to combine traditional forms of healing with solid science is what it's needed at this point. So that's one of the difference between Europe and the US. For instance, in the US, you can find clinics that will offer traditional Chinese medicine, but one of my field of expertise is traditional European medicine. It's possibly unknown here in the United States. What does it mean to have traditional European medicine in the first place? And many times when I mention this label, people might look at me and say, is this some sort of conspiracy theory with pseudoscientific claims mixed with shamanism, which is absolutely not true. But that kind of tells about the separation between, everything that led up to the fantastic discovery of Ibidem and the traditional remedies. That's one element. And the second element, of course, is universal healthcare and relatively free education in Europe, which allows for a more direct approach. To give us straight, for example, as I mentioned, the training of physician is the same, I would say, grossly speaking, between Europe and the United States. But the way physicians are perceived in Europe, it's still part of the tradition. So traditionally speaking, there was a difference between physician and surgeons, and that's part of what the name of the degree is in the UK and the Commonwealth countries. So you get a bachelor in surgery and medical bachelor. So the physician is the person who does research, and it's kind of on a higher standard, so to speak. And the surgeon used to be centuries ago the person who was hands-on actually operating on the patient. But then to be claimed to have a full doctorate, then you need to get a PhD in your field. So that's one of the differences between Europe and the United States. And another thing is the way mental health is perceived. So we mentioned Germany, we mentioned the United Kingdom. In Italy, for instance, there are no psychiatric facilities by law. There is no psychiatric hospital. There's no inpatient psychiatric units since 1976. And that was due to the implementation of this law called Legge Basaglia that attempted to understand mental health disorder as holistic disorders, as disorders that did not involve just a person, but society as a whole. So since the patient could get sick, society could get sick as well. And we need to be together in order to achieve a more, balanced outcomes. And from that background in Scandinavia, but especially in Finland, this open dialogue model was developed that allowed patients to actually not just be informed, but take part in the clinical decision making. So that is where I like to some extent, reinforce some European flavor to the US.
It's an interesting perspective, because then if what you're saying is the case, then that means society has a role and responsibility in helping and taking care of people, versus at times in the United States, we may have very much health is your responsibility. It's not your health is your responsibility, and I don't necessarily have an influence or responsibility over your health.
Yes, I like to think as, throwing a stone in a lake. You might be the stone, but then the reverberating effect of the waves will affect the surrounding environment. So we should probably move away from that kind of blame game. I'm guilty, I'm responsible. We're on this together. As cheesy as it may sound, that is actually the truth. Your environment will affect who you are, and you will play a role in affecting the environment.
As we start to come toward the end of this episode, how does your research help inform what's happening in today's opioid crisis? That's
our hope, that this research and similar research will really change the way we look at things. The opioid crisis, especially in the northeast of the United States, and unfortunately here in Vermont, we're playing a big prize, is to some extent a combination of societal mistakes, system mistakes, as well as lack of personal responsibility, or at least lack of personal knowledge, lack of empowerment. And we are guilty in this sense. I mean, the medical system, unfortunately, played a major role in the way opioids were prescribed in the mid-90s, starting in the mid-90s, and for the right reason. Nobody likes to see their patients suffering. So my colleagues, in the past and, that currently dealing with the opioid crisis did what in their minds seemed to be the moral, the ethical thing to do, so to prevent pain. But unfortunately, like with every other shortcuts, and pharmacological intervention is to some extent a shortcut, then you have to pay the price. The problem, it's not that painkillers are not working. The problem is that they're working too well. And people, of course, rely rightfully so on the trained ones, the experts in medicine, so doctors. And that's how the opioid crisis had a start in the mid-90s. But of course, nowadays, it became a much more complex issue. And beside prescription drugs, this addictive personality that our society is being kind of affected for the last 20 years or so is something that we're all in together. And there's something about exercise that, well, first of all, it's stimulating exactly the same neurotransmitters that would be otherwise, if not completely stimulated, but at least modulated by, antidepressant, for instance. So if you exercise, you're still going to target serotonin and dopamine and the endorphins and, GABA. So you're going to do exactly the same thing. I just want to make sure that people do not misinterpret that as let's just get rid of all medications and exercise instead. Those are two very different things. And just as in the previous example, when I mentioned you just need to move away to deal with your problems, that's not what I'm advocating here. But you can teach your body or reteach your body how to secrete and modulate those, neurochemical responses by way of controlling your body. So in that sense, you will have a more balanced way to deal with your problems. And I also want to mention that this should be something that will be very useful in this time of change, beside abuse of prescription drugs, painkillers, opioids, but also marijuana, for instance, that it's one of those substances that are often discussed in the public sphere. And unfortunately, just because of our very politicized environment, merge the scientific, the legal, and the moral or religious elements all together. And we had to make big distinctions. Like, for instance, while there is a strong evidence of the benefits of cannabinoids for, pain management, for instance, from cases, or hybrid management of physical pain and psychological pain as well, high tolerance of pain, a low threshold, like in fibromyalgia, for instance, there's plenty of evidence, mounting evidence. Then we have to be extremely careful when we deal with neuroreceptors that are especially sensitive to cannabinoids, because when we're dealing with mental health disorder, we are also playing with the fire. So while more and more research is needed to monitor the effects of any type of chemical intervention, whether it's plant-based or artificial lab-based, then exercise has virtually no side effects if it's done appropriately under supervision.
Yep. Well said. Something we talk about on this podcast all the time. We've been talking about it for, probably over 2 years now. So I want to thank everyone who follows along with that message. And it is getting out there. It is changing. But as you mentioned, these are problems that have multiple levels to them. David, it was great talking with you today. And I look forward to reading about more of your research. To close up, can you tell everyone how they can learn more about you and things you're up to?
Sure. They can go on my website, davidtomasi.eu, or just Google University of Vermont Integrative Health. That's our department. And there's a whole list of research studies and the programs that we offer, both for credits or just for continuing education. And of course, if you want to be updated with my research, you can go on Researchgate or Academia, and you can find all the free downloadable peer-reviewed papers there as well.
Excellent. So I want to thank David for joining us once again on the podcast this week. You can, of course, find out more information by going to www.davidtomasi.eu or go to University of Vermont and check out his page. I want to thank David once again. We're talking about the intersection between mental health, nutrition, and exercise. Make sure to share this out with your friends and family, and we'll see you next week.
Thank you for listening to the Healing Pain Podcast with Dr. Joe Tatta. To subscribe to the podcast and learn more, visit integrativepainscienceinstitute.com. That's Integrative Pain Science www.institute.com. Sign up to receive weekly updates, leave a review on iTunes, and share this episode with your friends.